infiltration or field block technique is usually successful in maxilla. Why? Because the bone, the type of bone in the maxilla is porous, it is cancellous bone, and the local anesthetic agent can penetrate the cancellous bone and reach the nerve and anesthetize the nerve. In contradiction to the mandible. The mandible is a compact bone, as you know, and it is difficult for the local anesthetic agent to diffuse through the compact bone because it is solid bone, and usually field block is not successful in the mandible unless in the anterior area of the mandible, because the bone is a little bit porous. So we can do infiltration here in the anterior teeth, but for posterior teeth, the molars and the premolars, never you can do field block or local infiltration. It will not be successful, definitely. So do not try to do local infiltration or full field block for molars and premolars. It will not be successful. Now let us talk about the technique, the landmark for field block or local infiltration as it is commonly named. So retraction of the lip, for example, or mucosa of the oral cavity, to identify this is the mucobuccal fold. This is the mucobuccal fold, which is one of the landmark. And my target area during field block is the apex of the tooth. The local anesthetic agent should be deposited along the apex of the tooth. And if you remember during our local anesthetic lecture, the needle should be parallel. We need to do the needle parallel, to hold it parallel to the long axis of the tooth. For example, let us assume that we want to do field block or local infiltration to lateral incisor. This is how to hold the lip, retraction. Now the mucobuccal fold, this is the insertion area. The point of entry is called the insertion area, and the needle should be held parallel, as you see, to the long axis of the tooth. Before it was 45 degree. This is now obsolete, because when you touch the bone, that means you will touch the periosteum. The periosteum is richly vascular, and in addition it is sensitive, so it will cause pain to the patient during the injection. So now no need to touch the bone, just go parallel to the long axis of the tooth, identify the mucobuccal fold, and deposit the local anesthetic agent opposite the apex of the tooth. How can I know the length of the root? The length of the root is known from the crown, because as you know, the root is twice the length of the crown, so I can estimate the length of the root and then enter into the mucobuccal fold like this, parallel. No need to touch the bone. About 3 to 4 millimeters when you are opposite the apical region of the tooth, then you can do aspiration and deposit your local anesthetic agent. Usually local anesthetic in the cartridge, this is a dose. You have to finish about 3/4 of the needle on the buccal side, and then leave 1/4 for the palatal injection. This is if you are doing, for example, extraction. You need to anesthetize the tissue on the buccal and the palatal aspect. If you are doing RCT or restorative filling or other procedure where you do not need the soft tissue anesthesia, unless you are fitting a rubber dam. For rubber dam you need to do local anesthesia, because sometimes the clamp will cause pain by pressure on the gingiva, so you need to give the palatal soft tissue also during the injection. Now you can imagine how this syringe is held. Before, as I said, it was like this, 45, and this is now obsolete. Please do not do like this. So when you do like this, when I observe you during, that means your technique is wrong. This is the proper way of doing the field block technique, parallel to the tooth. As we said, the root length, the crown, the mucobuccal fold, these are the landmark for the field block technique or the local infiltration. And the same procedure as you have shown already can be done with all the teeth, although sometimes it is difficult to do this in posterior teeth like the upper third molar, but you need to do retraction with the dental mirror or retractor. You can do it if you are careful about that. First, you have to identify the incisive papilla, and all of you know how the incisive papilla look like. Between the two central incisors, there is an elevation of soft tissue, palatal soft tissue. This is called the incisive papilla. This incisive papilla immediately lies over the incisive canal on the palate, and this incisive canal transmits the nasopalatine nerve. The nasopalatine nerve, if it is anesthetized, it will anesthetize the tissue from premolar, the palatal tissue from the canine to canine. If you do block here over the incisive papilla and aiming to the incisive canal, then this is how to do it, through the incisive papilla laterally with an angulation of 45 degrees, and you do not need to go inside the canal. If you go inside the canal, it is okay. If you could not negotiate the canal, no problem. You can deposit the local anesthetic at the entrance of the canal, and it will diffuse. As you know, the local anesthetic will diffuse and reach the nerve. So this is how the nasopalatine nerve block is done. And when you enter, actually, you will enter about 4 to 5 millimeter deep into the soft palate, and you know, do not try to give large amount of local anesthetic because the tissues here are tough and it is painful. So when you do, and also during the injection, you will experience pressure, resistance to the injection. So sometimes the solution will come back, and sometimes it squares back into your face. So only about 0.3 to 5.5 mil are quite enough to anesthetize the nasopalatine nerve. This is if you need the soft tissue of the palate from canine to canine, okay? For example, extraction, fitting of a rubber dam, or whatever technique. The premolars, first and second, and molars, as you know, are supplied by the greater palatine nerve. And observe please here, this is the mid-palatal suture or rough, and this is the gingival margin. Midway between these two structures, you insert your needle like this, perpendicular to the palatal mucosa. And if you want to block the greater palatine nerve, the greater palatine foramen is situated between third molar and second molar. So please do not give injection opposite the third molar, because you see here, this is the soft palate, and when you give anesthesia opposite the third molar, that means you will anesthetize the soft palate, and the patient will develop gagging reflex, and it is very disturbing to the patient. So just give the anesthetic agent midway between the gingival margin and the mid-palatal rough or suture, and this is the area just distal to the second molar, just distal to the second molar in this area, until you feel the bone, and deposit about 0.5 mil of local anesthetic, yani almost 1/3 of the cartridge. 1/3 of the cartridge, it is quite enough to anesthetize the greater palatine nerve or block the palatine nerve. And by this technique, the third molar, first molar, second molar, first premolar and second molar, the soft tissue on this aspect will be anesthetized. Now we will discuss the most commonly used mandibular technique, the inferior alveolar nerve block. And really, all of us, sometimes we have a problem in obtaining anesthesia through the inferior alveolar nerve block. In literature, the failure rate of inferior alveolar nerve block is 15 to 20% of the cases. There is failure. So don't worry, don't be depressed, and don't be frustrated. It happens to everybody, even to the very experienced dentists or operators. It happens that they fail to obtain inferior alveolar nerve block anesthesia. So, as you know, for block technique, inferior mandibular technique, we need long needle, and we say the length of the needle is between 32 millimeter until 40 millimeter. This is the length of a long needle. So now we are fitting the long needle. We need to prepare for inferior alveolar nerve block. For inferior alveolar nerve block, there is a lot of landmark that can be used for example, the coronoid process, the sigmoid notch of the mandible, and the external oblique ridge, the internal oblique ridge, and a lot of landmark. But during our clinical session, we only use 4 clinical landmarks, and it is very easy to remember. So, what is this landmark? 4 landmark usually we use for inferior alveolar nerve block. First, as we said, this is occlusal plane of mandibular teeth. This is one of the landmark, and the needle should be above the occlusal plane by 6 millimeter to 10 millimeter, as you remember during our local anesthesia lectures, and as you know, it is written in our reference book, Malamet, Handbook of Local Anesthesia. So occlusal plane is one of the landmark, and the syringe should be above the occlusal plane by 6 millimeter to 10 millimeters. So occlusal plane, for example, let us assume that I want to anesthetize or do inferior alveolar nerve block on the left side, this side. So the premolar from the opposite side is the second landmark. The premolars from the opposite side is the second landmark. And what is the third landmark? The coronoid notch. What is the coronoid notch? The coronoid notch is the deepest concavity on the anterior border of the ramus. You have to palpate with the thumb. Do palpation up and down until you feel the deepest concavity on the anterior border of the ramus. The fourth, the first is the occlusal plane, the second is the premolars from the opposite side, and the third is the coronoid notch, the deepest concavity on the anterior border of the ramus, and the fourth landmark, it is soft tissue. It is the pterygomandibular raphe. The pterygomandibular raphe is a soft tissue. It is a fold of it will appear clinically as you see here. It will appear as a fold of mucous membrane. When you ask the patient to open the mouth, then you will see this fold of mucous membrane. What is the pterygomandibular raphe? It is a junction between 2 muscles. What is this 2 muscle? It is the buccinator muscle and the superior pharyngeal constrictor muscle. This junction, or the area of union of these 2 muscles, it is called pterygomandibular raphe, and it is a soft tissue, fibrous tissue band. It is a fibrous tissue band connecting these 2 muscles. Please remember that. And when you see it clinically, as I said, just ask the patient to open the mouth wide, and you will see this fold of mucous membrane. The injection should be anterior to this pterygomandibular raphe. When the patient open mouth, you will see this fold of mucous membrane. Immediately anterior to this fold of mucous membrane, you will see this triangular area. You see this depression, this depressed triangular area. This is the point of entry of your needle. Immediately anterior between the 2 premolar from the other side, above the occlusal plane, and this is the point of entry of your needle. Please enter slowly, go slowly until you feel the bone. When you touch the bone, a very important thing you have to remember, about 3/4 of the needle should be inside the soft tissue. When you touch the bone, remember that about 3/4, for example, you see this? Now I am touching bone, but you see almost all the needle is outside. That means yes, I am touching the bone, but in the wrong area. So what will happen if I inject here? That means my local anesthesia or my inferior alveolar block, it will fail, definitely. Why? Because the solution is deposited away from the mandibular foramen. So remember this please. When you go inside soft tissue, look at your needle. How much of your needle is inside soft tissue? If it's like this, please do not do like that and like that. Just withdraw the needle and re-inject. And do not move the needle inside soft tissue, because this needle, it will fracture and it will cause a problem to the patient. So now between the two premolars, and this indicator indicates the bevel, as you see, and the bevel should be facing towards the bone and immediately above interior. As you see, this is my point of entry, like this, slowly until you feel the bone. Now you see almost 3/4 of the needle is inside the soft tissue. This, I assume we are right. Now do aspiration, look at your cartridge, and if there is no blood in the cartridge, that means aspiration is negative, and just start to inject slowly. Injection should be slowly, because rapid injection is painful to the patient. Slowly, as if you remember, we said this 2 ml or 1.8 ml should be emptied or in 2 minutes. Yani 1 ml in every 1 minute. This is the rate of your injection. You see, this is the situation. Anterior to the raphe, into the depression area, this triangular depressed area, and when you touch bone, please go back 1 millimeter. Why? Because if you press against the bone and give the injection, that means it will be subperiosteal injection. Subperiosteal is painful to the patient, and it will develop hematoma and infection after the injection. So this is our rule. All injections are supraperiosteal, above the periosteum. Subperiosteal, اللي هي تحت الperiosteum, this is contraindicated. We should not do it. You see now I finished with the block. I have to go back half the distance and then give 0.5 ml for the lingual nerve. Go out half the distance. For example, let us assume that you entered about 30 millimeter, so you have to go back about 15 millimeter اللي هي نصف المسافة, and then give the lingual nerve about 0.5 ml. Half of the cartridge for the inferior alveolar, 0.5 ml for the lingual nerve. Now I give the lingual nerve. I can slowly also withdraw your needle slowly and get out from soft tissue. The long buccal nerve. How to anesthetize the long buccal nerve? Just please use a thumb, retract the lip and cheek, and place your finger here. What is this structure? This is the external oblique ridge. My finger is on the external oblique ridge, and you see the bevel facing the bone. The needle should go parallel to the occlusal plane and enter immediately anterior to your finger, like this. Now you see, I touch the bone. This is the external oblique ridge. Yani you need only to enter about 3 millimeter. You will find yourself touching the bone. This is a long buccal nerve block, and deposit the remaining of the cartridge. Here about 0.3 ml. It is quite enough to anesthetize the long buccal nerve. Now, if you block the long buccal nerve, this soft tissue until the first molar will be anesthetized. The gum and the mucosa on the buccal aspect will be anesthetized until the first molar is anesthetized. Now I can do extraction. What is the other approach? It's the same thing, retraction of the lip and cheek, and place the finger, the needle like this, and you come from here also. Now I touch the external oblique ridge. You see, I can meet here the same. The target area is the same, but the approach is different. You can come from the buccal, or you can come from this area to anesthetize the long buccal nerve. Why this area? Because the long buccal comes from the medial side of the ramus of the mandible, and it crosses the anterior border of the ramus like this. So I just need to meet it here and block it. So this is the long buccal nerve block. This is first approach, and this is the second approach. It is the same area, but with different approaches. Now I am ready for doing my procedure, extraction, surgical removal of said molar or whatever flap, because soft tissue buccally and lingually and the inferior are blocked. So the bone, the periodontal ligament, the tooth and the soft tissue are anesthetized. This is regarding the inferior ulnar block. And we have other techniques. This is the two common, and as I said about inferior, don't be frustrated. It happens sometimes. It is not effective. It is not successful. And as I said, the percentage is 15 to 20% failure with inferior alveolar nerve block. So you can do your anesthesia again, revise your technique, and do it again until you obtain the level of anesthesia required for your procedure. Is it okay?
يعطيك العافية دكتور.